Here we go. Let's do it. Okay. Sweet. Yeah, there's no point in me sitting all by myself and not recording, and maybe this will help somebody. So here we go. We're going to study. You're going to study with me. Here we go. Okay. All right. I was doing pretty good for like cramming and waiting to the last minute to refresh. A 45-year-old woman with a history of palpitations develops lightheadedness and palpitations. She's received adenosine 6 milligrams IV for the rhythms shown here without conversion of the rhythm. She is now extremely apprehensive. Her blood pressure is 128/70. What is the next appropriate intervention? So I think this one again is do vagal maneuvers. Here it is. Am I going to make you hang out with me? Here we go. Okay. So she's had adenosine. She needs a second dose of 12. So it goes 6 to 12. Right? Correct. Nice. Patient's been resuscitated from cardiac arrest. During post-ROSC treatment, the patient becomes unresponsive with the rhythm shown here. Which action is indicated next? A shock. CPR, if that's an option. Higher energy shock. So that's VFib. Oh, it's VTAC. So that's a shockable rhythm. There we go. Nice. All right. How does complete chest recoil contribute to effective CPR? This is something that I'm very adamant about checking during codes. I'm a compression queen, by the way. Allows maximum blood return to the heart, right? You have to complete circulation. You're trying to pump fresh blood through the body. It's the only way to capture the effectiveness of your rescue breathing. So allows maximum blood to return to the heart. I didn't even read. Bad advice is not reading the rest of the answers just in case, but this one is super important to know. Which actions should you take immediately after providing an AED shock? Compressions, right? Resume chest compressions. If that's an option, it's always the answer. Okay, okay. You arrive on the scene to find CPR in progress. Nursing staff report the patient was recovering from a pulmonary embolism and suddenly collapsed. 2 shocks have been delivered. So that means this is VFib. Sometimes, this is VFib. If you've ever had a test where you confused very fine VFib with asystole, raise your hand. Okay, an IV has been initiated. What do you administer now? First drug you always administer is epinephrine, 1 milligram. Okay, practical application. Section 3. So I've already done the first 2 sections. Rhythms. I always need to review rhythms because working in the ER is just like, are they dying? Like, oh, that's bad. Oh, that's good. Like, it can wait. I mean, you have to triage your rhythms. So definitely never worked in like a cardiac ICU. That's not me. I can tell you if a fetus is dying. Anyway, let's not get off track here. Okay, here we go. What is the maximum interval for pausing chest compressions? 10 seconds. What is the recommended depth of chest compressions for an adult victim? At least 2 inches. You were the code team leader and arrived to find a patient with CPR in progress. On the next rhythm check, you see the rhythm shown here. Team members tell you that the patient was well, but retorted Pest discomfort and then collapsed. She has no pulse or respirations. Bag mask ventilations are producing visible chest rise, and IO has been established. Which intervention would be your next action? No pulse. This looks like normal sinus rhythm, but she doesn't have a pulse. So it's not shockable. We're going to give epinephrine. Okay. Ugh, it's ugly. There's a STEMI. When the patient arrives in the emergency department, the rhythm shown here is seen on the cardiac monitor. The patient has resolution of moderate chest pain after 3 doses of sublingual nitroglycerin. Blood pressure is 104/70. Which intervention is most important in reducing this patient's in-hospital and 30-day mortality rate? Reperfusion? Ha. Nice. That's an ICU question. Okay. Your patient is a 56-year-old woman with a history of type 2 diabetes who reports feeling dizzy. She's pale and diaphoretic. Her blood pressure is 80/60. The cardiac monitor documents the rhythm shown here. She's receiving oxygen at 4 liters a minute by nasal cannula, and an IV has been established. What do you administer next? So, is this Brady? I don't think she needs atropine. Glucose? No, because she's got a low pressure. So, is it dopamine? No, it's atropine. So that is Brady. Damn it. Who's with me? Okay, cool. What is the recommended compression rate for high quality CPR? Nail it. Notice it's the highest one. You're providing bag mask ventilations to a patient in respiratory arrest. How often should you provide ventilations? Every 6 seconds. So the first code I was ever in, here I was with the bag mask pumping away because I was freaking out. And they like swapped me out. Luckily, there were enough nurses there, totally competent people. And this woman was terminal and didn't have an advance directive. So of course it was good for me because I got to see kind of a slow code and they just actually just went through everything. So that was nice, but God, it was scary. It was a new grad. Oh, which action is likely to cause air to enter the victim's stomach during bag mask ventilation? This is such a good follow-up questions. Ventilating too quickly. Yeah. Bad news bears. It's not good. Correct. Okay. Which action minimizes the risk of air entering the victim's stomach during bag mask ventilation? Is it listening to me? Ventilating until you see the chest rise? Yes. And not going over? Yes. Just until you see chest rise and then let it go. And then wait 5 seconds and then get ready and give some more. How often should you switch chest compressors to avoid fatigue? About every 2 minutes, which is 5 cycles of good chest compressions every 2 minutes. 2 minutes is long enough to get tired. All right, is that more VFib? After initiation of CPR and 1 shock for VFib, this rhythm is present on the next rhythm check. A second shock is given because it's still VFib, and chest compressions are resumed immediately. An IV is in place and no drugs have been given. Bag mask ventilations are producing visible chest rise. What's your next intervention? No drugs have been given. So we've done everything else. So the first drug is always epinephrine. And 1 milligram, because that's easy to remember. What is this? Some kind of block. Patient becomes unresponsive. You're uncertain if a faint pulse is present. The rhythm shown here is seen on the cardiac monitor, so we know it's not a shockable rhythm if this is what it looks like. An IV is in place. What action do you take next? So always start high quality CPR if that's an option, because you don't know if there's a pulse. So you got to make a pulse. Think of CPR as you making a pulse. You have to be that pulse. As soon as you stop CPR, you're stopping the pulse. Oh, cool. 78% because I got all those rhythms in the beginning like super wrong. Okay, here's how I scored. Let's check it out. Rhythm identification. What did I tell you? Well, I'm glad I know my practical application. That's great. Okay, fabulous. Bradycardia, coronary syndrome. Yeah, bradycardia algorithm, stroke algorithm. I missed the 2 atropine questions. Nitro question. Aspirin and fibrinolytics. Okay, cool. Print. Does that have the date on it? Hmm. So print that. Okay. Ugh. Continue. Thank you. Okay, exit exercise. Mm-hmm. Hold on. Well,
Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves.
That's helpful to know because I'm always screaming about how they don't ever wear gloves.
Across the United States, survival rates for cardiac arrest, acute coronary syndromes, and stroke vary considerably from region to region.
It's important that EMS, the emergency department, and in-hospital providers work together, not only to deliver better patient care, but to strengthen the chain of survival for future cardiovascular patients.
That starts with identifying the weak points in your system's chain of survival. Gathering data and measuring patient outcomes can identify areas that need improvement.
To deliver the highest quality patient care by using this team approach, there must be an integration of community, EMS, physician, and hospital resources.
This process must focus on prevention and preparedness, immediate recognition of cardiac arrest and activation of the emergency response system, efficient functioning of high-performance teams, including early high-quality CPR with an emphasis on chest compressions, rapid defibrillation, effective advanced life support, integrated post-cardiac arrest care, and recovery.
To deliver the highest quality patient care, integrated systems of care should include in-hospital medical emergency teams and rapid response teams, often referred to as METs and RRTs.
These teams typically consist of healthcare providers with both critical care or emergency care experience and the skills to support immediate intervention for life-threatening situations based on early detection. These teams are responsible for performing a rapid patient assessment and initiating appropriate treatment to reverse physiologic deterioration and prevent a poor outcome.
Some rapid response systems use specific physiologic criteria to determine when to call the team.
The American Heart Association recommends that hospitals establish a rapid response system. In the more than 5 decades since chest compressions were first attempted on a cardiac arrest patient, there have been significant improvements in the treatment of acute cardiovascular disease.
Research confirms that high-quality CPR as a foundation of high-performance teams is crucial for successful resuscitation. Feedback devices have proven beneficial in maintaining high-quality CPR.
But there is much more work to be done. With the latest research pointing to new, quantifiable ways to improve patient outcomes, advanced providers have more tools than ever before to reduce disability and death caused by cardiovascular diseases and stroke.